Dr. Chang is our invited speaker for the evening. She is an associate professor in the Division of Gastroenterology, where she specializes in IBD at NYU Langone's Health Inflammatory Bowel Center in New York City. She completed her internal medicine residency at Mount Sinai in New York and her gastroenterology fellowship at NYU. Dr. Chang is the Director of Clinical Operations at the NYU IBD Center, and her areas of clinical and research interest include the ileal pouch anal anastomosis and novel diagnostic and management options for use in IBD. And she's also an author on more than 80 peer-reviewed publications. So we're really excited to have you tonight, Dr. Chang.
Hi, everyone. Thanks so much for joining on this Sunday night. I wanted to thank Karishma and Hande for the invitation to speak today about one of my favorite topics. So at NYU, we have our own IBD service. It's actually a colorectal surgery primary IBD service. So it's a little bit different how we do it, but I think it really lends to this conversation tonight for you guys about sort of what we feel as gastroenterologists, colorectal surgery residents, fellows, and attendings should try to take away from this lecture. So I've tried to sort of give some clinical pearls as we move through as it relates to colorectal surgery. But the focus of today is going to be on IBD medical management for the colorectal surgeon. A lot of it's going to be inpatient, and then some of it's going to be focusing on, our cool new medications that we have. Okay, so these are my disclosures. The objectives for tonight, we want to understand the initial medical workup for hospitalized IBD patients. Why do we do what we do? Why do we tell you, at least at NYU, what medications to order and what labs to order? Recognize medical therapies used for steroid refractory acute severe ulcerative colitis and be familiar, not necessarily to prescribe, but be familiar with commonly used treatments for ulcerative colitis and Crohn's disease that you might see for these patients that come with UC and Crohn's. Okay, so we're going to start by talking about inpatient acute severe ulcerative colitis, but I'm going to caveat this and say that we could also be talking about Crohn's colitis or just a Crohn's flare. For many situations, we may sort of off-label go that way, and it is something that we do see. So even though we're just talking about UC, it could be Crohn's colitis, and I want you guys to just keep that in mind. So when we talk about severe UC, there's many different definitions out there, including True Love and Wits, the Mayo score, which is probably the most common, or the Lichtiger score, which is a little bit older, named after Simon Lichtiger. So the True Love and Wits is the most commonly used in papers, and then for clinical trials, total Mayo score. Common to all of these are, what's the bowel frequency? And it's not just the number of times that the patient has a stool, it's the number of times that they actually sit on the toilet to expel mucus, blood, or stool. So a lot of times, we'll have a report that the patient's been going like 5 times a day, but if you really drill down on the history, they're actually sitting on the toilet hourly, right? Because they've got that urgency, and it really speaks more to the severity of illness and the symptomatology. Blood in the stool is never good, so we always see that within the scores. And then there's a variety of other assessments: abdominal tenderness, your vital signs, so elevated temperature, your pulse being greater than 90 in some of the scores. And then we're looking at labs. So CRP, we use a lot. We trend it daily for these patients. Hemoglobin, if you are anemic, that's always, a question of whether it's an iron deficiency, whether it's marrow suppression, but hemoglobin less than 75% of normal is concerning. And then other things like incontinence have been worked into other scores. In the GI Society sort of guidelines, they do outline these things at the bottom, these criteria, as you can see here, a lot of which combine a lot of the different criteria from the other definitions over time, but this should give you guys a flavor. We're looking at vital signs, we're looking at their symptoms, we're looking at their labs when they come in to try to decide, is this, going towards a more severe course for this patient. So for acute severe UC, up to 25% of patients might meet criteria for this in their lifetime. And in this setting, up to 30 to 40% of them will fail steroids, either inpatient or outpatient, and they may require colectomy in the short term. So 18% of these patients undergo colectomy during an inpatient admission for acute severe UC. For our hospital, I think we ran those numbers and it's somewhere, I think surgery with about 10% of the inpatients that are admitted, but that's a mix of UC and Crohn's. But so I think this number is pretty representative. And so these patients do need extra consideration, even if they're young, even if they look completely healthy when they come in. Up to 40% at the second admission will have surgery, and then 60% after 3 years. So the more admissions you have, assuming that the medical care has been optimized, right? And there's not like insurance issues or something else going on behind the scenes, but assuming adequate medical care optimization, the more UC admissions you have, the more that you're going to see a little bit of that writing on the wall. So signs of toxic colitis, this is very important. So as colorectal surgeons, the one thing that you don't want to miss is a patient going toxic, right? And so you're looking at the vital signs. Are they febrile? Are they tachycardic? Is it just fluid depletion, or is it actually that they are having like a toxic, they're actually toxic, right? Their hemoglobin is low. Their leukocytosis is rising. Albumin less than 3. For colitis, this is a protein-losing colopathy. Albumin is lost, and that is a sign of a sick colon and or potentially a surrogate for malnutrition as well. Elevated CRP rising. I will tell you, for patients that we have seen that have gone toxic and or had like a microperforation or contained perf, sometimes that CRP jumps 100 points overnight. So always be afraid of that if you see it, and really pay attention to that patient. Worsening abdominal pain. And then this is counterintuitive, but this is a sign of impending toxic megacolon. If they look sick and then all of a sudden they don't have any bowel movements, or they're like, whoa, it was great. Yesterday I went 20 times and today I've gone once, but they look really uncomfortable, then you have to be concerned and get that flat plate KUB, make sure they're not dilating. This is very important. You do not have to have guarding or rebound or signs of peritonitis to have toxic megacolon or toxic colitis. This we have seen. It is a huge, I would say, education gap for some people not familiar with IBD. You want to look at the patient as a whole. If they're having intractable pain, but they're not peritonitic, that does not mean that they're not toxic. You want to really talk to an IBD specialist about this if that is happening. And if they're tachycardic and they're febrile and you can't explain why, you really, really, really need to have a multidisciplinary discussion about that patient. Imaging can be supportive, but it's not required for a diagnosis of toxic colitis. So if you think that clinically this patient looks like they're moving towards colectomy, but there's no free air and there's no dilation per se on a scan, it doesn't necessarily mean that patient doesn't need a colectomy. Okay, so it's just talking to the GI doctor, the colorectal surgeon, radiology, getting everyone involved for consensus there is very important. Okay. All right. So when you are seeing a patient with acute severe UC in the hospital, there's of course algorithms to be followed. So when they're admitted, the essential studies that we always send are their hemoglobin, albumin, CRP. As previously stated, these are markers of severity of illness. Then, of course, we want to get them ready if they're going to need a biologic during the hospitalization. So we send a Quant Gold, and then we send the Hep B labs. And I know it's always confusing which ones to send. So you want to look at the S antibody, S antigen, and core antibody. And I don't know, for the people that are watching this, how many people are going to actually be primary sending these labs themselves, but at least you understand sort of what the purpose of the labs are. But again, at our hospital, colorectal surgeons put in the orders for all of this. So we've done a lot of education and they do an amazing job with it. We also created an order set, so it's also a lot easier. Cholesterol, if your institution offers cyclosporin, that is something that we would like at admission, just to get a sense of, do they meet criteria for safe administration of cyclosporin? A KUB, you don't need a CAT scan. I know everyone that comes through the ER gets a CAT scan, but unless you're really concerned about a perf or some sort of question about their diagnosis, or something questionable in their history, we usually just, for the UC patients, shoot a KUB when they come in. Stool testing, we always send a C. diff test at admission because C. diff is very prevalent in this population. And you don't have to have a characteristic smell. You don't have to have a leukocytosis. Like it's just something that, as per our guidelines, but also it's really hard to just sort out whether the flare is from C. diff or UC. So we always send that. And we do send now a 2-step C. diff test. So it's a PCR and then the toxin EIA. Okay, so if you can do that at admission, that would be great. Okay, so the other thing that's very important is, unless the patient just came straight from their gastroenterologist's office and was admitted, we do a flex sig within 72 hours of admission. We do that to look at the endoscopic severity. A picture is worth 1,000 words, right? If you go in and there's deep punched out ulcerations everywhere, or the entire circumference of that rectal mucosa sigmoid is just ulcer, then you know that this patient is extremely high risk for colectomy. On the other side, if you go in and it's just a little bit of proctitis, you're happy. And then you say, okay, like let's do our medical therapy and try to get them out of the hospital. So it's very, very important. And then we always biopsy for CMV. CMV, known as cytomegalovirus, can be, particularly in immunosuppressed patients, a source of colitis. And then in others, it can be what we call an innocent bystander. So it's very important for you to work with pathology if there are CMV cells to find out if it's just a few, that maybe is an innocent bystander. If there are a lot of cells, we usually send a CMV serum PCR quant to see if there is viremia ongoing, and then they would get concomitant treatment for that. So the typical course, you come in, we send these labs, we do the sigmoidoscopy, we treat with IV steroids, and we assess a response around 3 days. So there's a little bit of a watch and wait period over those first couple of days, but that's what the patient's going to be doing. As I said, we do send a C. diff because we see for UC, a little bit less for Crohn's, but for UC in particular, there is a rising incidence of C. diff cases. And I'm sure we see this in all of our hospitals. C. diff is not just a hospital-acquired infection. It can be obtained in the community. And these patients do have high touch points with healthcare anyways. And then sometimes antibiotics are given. So, but they don't have to have an antibiotic exposure necessarily. When you have active colitis, the mucosal immunity is down, the mucosal barrier protection is down, so it's kind of what we call leaky, and so those infections are more prevalent in this population. So general principles of inpatient management, what are those gastroenterologists doing? So we, at the beginning, after you've looked at their labs and said, okay, this patient needs to be admitted for acute severe UC, we start IV steroids. The dosing of it highly varies by hospital, but it's going to be methylprednisolone, which is Solumedrol, 60 milligrams a day. We usually do 60 times 1 and then 20 Q8 at my hospital. At the hospital next door, which is also part of NYU, we do methylprednisolone 60 once a day. And partly that's just because it's easier for staffing ratios, just because there's a lot of patients there at our city hospitals. So, but either way, they're getting about 60 milligrams a day. IV. Hydrocortisone can also be given 300 IV daily or 100 Q8. Antibiotics, they are generally not needed for treatment of ulcerative colitis. There's really no role for them in terms of decreasing inflammation. But of course, if you're worried about sepsis, bacteremia, perforation, of course, we add appropriate enteric coverage. And then, of course, if the patient tests positive for C. diff, then we do also treat C. diff with either vanc or Difficid, depending on what's available. A word about C. diff and treatment. So it is some people's practice, if the patient has C. diff, that they just treat the C. diff and they won't start steroids, but that usually doesn't work. And so you really want to treat those two processes in parallel. So you have a C. diff infection, you treat that, and that will be okay. And then you do your flex sig, and if you do see inflammation, then you can be sure that in addition to C. diff, there's probably also a UC flare going on. So you need to treat those in parallel. Depending on the hospital that you're at, So I usually tell patients when they're in the ER, like we'll start steroids right away. That C. diff is quick. For at least the first step PCR comes back really quickly for us. So maybe they've gotten one dose of steroids while we're waiting, but then we'll have the answer for the C. diff. When the C. diff is positive for the PCR and they need that EIA done, it's reflex to the EIA. We'll put on prophylactic vancomycin in the interim until the EIA comes back. But if it's negative, then we'll stop it after that because it's not a true infection. It's just colonization. We want to try as best as we can to avoid narcotics in these patients. A lot of these patients will have chronic pain. We usually try just Tylenol. If it's very severe, they can get a dose of morphine or Dilaudid, but in general, best practice avoidance of narcotics, pain management, treating the inflammation will help a lot with the pain. Always these patients, even if they're young, even if they're ambulatory, they get pharmacologic DVT prophylaxis. And then we always make it a practice that they meet the surgeon early. Okay, if you're coming in for acute severe UC, we want them to get familiar with all of the possibilities, including possible need for colectomy during an admission. And if not during that admission, a different admission or never at all. But it is our practice to have them meet the whole team in the event that that is necessary. And I think as everyone on the call probably resonates here, it's probably easier not to be at the bedside having that discussion the day you want to take someone to the OR. And so we always have them meet them day one. There's a little bit of confusion sometimes, but we always say, everybody meets the team on the first day and it usually goes fine. And I picked out two papers that I really liked sort of the idea behind why you would do the study. They're not necessarily big studies, but it really speaks to how we want to think about taking care of these in-patients with acute severe UC. So one is on nutrition. So we see a lot of patients go NPO when they come in for acute severe UC, even if like they're not going for a procedure, that we don't think they're going for colectomy, we're just putting them on steroids and letting them sit there for a couple of days. So there's this concept of physician-delivered malnutrition. In the ADORE UC study, 44% of patients on retrospective chart review were NPO or on clear liquid diets for no clear reason, okay? On average, 3 days, those patients were on an inappropriate diet. So we don't need patients on clears. We don't need them to be NPO unless they're going for a procedure or you think that they're going to the OR. So they can be on a low fiber diet. I think raw fruits and vegetables are going to be really hard on someone who's flaring, but in general, they can still have solid meals. So try to think about that when the orders are in for that, because there's actually no proof that starving that patient helps with recovery of the colitis. And then another study looked at DVT prophylaxis. And this was a Canadian study retrospectively that found that overall 77%, 3/4 of patients received VT prophylaxis overall, but only 36% were given that prophylaxis on day one. When you have active inflammation in your bowels, you are prothrombotic. And that is really counterintuitive to a lot of people. And also the other thing we hear all the time is, but they're bleeding, okay? So unless they are bleeding out from their UC, which is extremely rare, they should all be receiving pharmacologic DVT prophylaxis to prevent possible catastrophic complications from thrombosis. And we do see this, especially when their colitis is very active. Okay, so we were giving the IV steroids. 1 in 3 of these patients will fail IV steroids, okay? So around day 3, we dichotomize people into responders and non-responders. Responders get to leave the hospital with a steroid taper. Usually that's something like prednisone 40 to start, and then coming down like 30, 20, 15, 10, 5. If they're, depending on what they came in with, then it might be like every 7 days or every 5 days. If they're not tolerating it very well, like the GI doctors and the outpatient will switch it. And of course, prednisone is not their end game. It's always going to have another discussion with their GI doctor what their maintenance medication will be. moving forward. If it was kind of a mild colitis, mesalamine might be something that you try and fail on a prednisone taper, but we have a lot of different options. This slide is a little bit outdated because it says that you might go to like azathioprine or 6-MP or like a mesalamine, like a 5-ASA. There's lots of different options now, and we'll talk about that a little bit at the end. The non-responders, they stay. They're either going to have surgery or they're going to get second line, what we call salvage or rescue medical therapy. So for steroid refractory acute severe UC, depending on where you are practicing, if you guys are involved in the decision for whether or not a person stays or goes from your hospital, think about transferring them to a dedicated IBD service because the outcomes are better. There's reduced mortality for surgical patients who go to IBD centers for surgery. There's expertise in rescue therapy. So the increased use of more aggressive biologic therapy for induction can help improve outcomes and also improve remission at 90 days. The workhorse of rescue therapy for acute severe UC inpatient is infliximab. Infliximab, the originator is called Remicade. And then now you're going to see, depending on what contract your hospital has, you're going to see probably a lot of the biosimilars. So there's Renflexis, Inflectra, Absol. Those are the main ones. So I'm probably missing one of them. But so any of those are considered fine to use. You can use the same drug levels. You can't switch between them. If one person has antibodies to Remicade, you can't give them Renflexis because they're just going to have a reaction to it. They're so similar. They're considered just infliximab. They're not quite generic, but they're called biosimilars. So infliximab is great because if you respond to it, of which around, let's call it 70%, then they can leave the hospital and get their next doses of infliximab outside the hospital, and that's their maintenance agent. And the long-term response rates greater than a year are somewhere between 50 and 65%. And it's something that is tried and true. And if you respond to infliximab, you could be in remission on it for decades for some people. Infliximab is a little bit finicky though. There are things that affect how much drug stays in the person's body and how fast the person clears it. And that includes an increased BMI, they clear it faster. So you want to look at sort of the overall habitus of the patient. Males clear it faster than females. If your albumin is low, infliximab binds to albumin. And so we'll see on the next slide why that matters. But if your albumin is low, sometimes we need to give more. If your CRP is high or the inflammatory burden is high, if they have a pancolitis, then that means there's more drug that is necessary to calm down what's happening inside. If they have any antibodies to infliximab, that can be tough to overcome depending on if it's neutralizing or non-neutralizing antibodies. And then if they're using concomitant immunosuppressive medications such as thiopurines, that can help decrease antibodies and improve drug levels. So we talked a little bit about factors for clearance. So fecal loss and non-response for infliximab patients. So we talked about the impaired mucosal barriers in severe UC. So that albumin leaks out in a protein-losing colopathy, and infliximab, when it's administered, actually binds to that albumin, and then people lose the infliximab in the stool. So you can see in this right picture here, this was a really great study that showed that for non-responders, you see their fecal infliximab levels actually peak just at the first or second day after administration of drug. So they're physically pooping the drug out, and that's not good because then it's not going to be able to help them, right? So the sicker the colon, the more drug that we sometimes have to give to overcome that. And so you might see someone gets drug one day, and then the next time they're supposed to get it is 2 weeks later, but we do sometimes accelerate that, give them an extra dose. Okay, so we're looking here down at the bottom. If you have a partial response to infliximab, as I mentioned, so you've gotten the steroids, you failed that, so we made the decision to go for salvage therapy. You give the first dose of infliximab, you assess that response a couple days later. If you see that they're feeling better, but then all of a sudden they start to get worse again, you want to think, okay, well, they're starting to run out of drug. And if that CRP went down and then starts to come up again, you want to think, okay, maybe we need to give a second inpatient dose. So after that partial response, we'll consider another dose of infliximab, usually 10 milligrams per kilogram, and then we watch there. If there's really no response, then we'll be talking about a second agent or just a colectomy at that time. So we talked a little bit about that accelerated dosing. So the standard dosing of infliximab is going to be the first time, 2 weeks later, 6 weeks after the first dose. But sometimes we will give more because it has shown short-term benefits for these patients. So on the left here, you can see this accelerated dosing group, patients that needed an extra dose based on their symptoms versus the standard dosing. They were more likely to avoid colectomy during induction compared to the standard dosing patients. However, looking at the long term, the story is not as clear here. This was showing that these patients required similar rates of colectomy over the next couple of years after these dosing. Caveat here, this was the standard dosing, 5 milligrams per kilogram, and a lot of times because we're giving higher doses. So in response to that was the PREDICT-UC study, which looked at optimizing infliximab induction therapy. This was open label in several centers in Australia. They had 3 arms. One was standard dosing. Second was a modified dosing where it was 5 milligrams per kilogram, and you can get an extra dose if you wanted based on clinical signs. And then the third was just giving 2 rapid fire 10 milligrams per kilogram at week 0 and 1. We found that in the PREDICT-UC study that the higher and lower doses achieved similar clinical response rates by day 7, but the intensifying or accelerated induction achieved clinical and biochemical outcomes earlier compared to standard induction. And then patients with lower albumin, as we talked about before, they seem to do a little bit better at 3 months if they had that proactive intensified dosing strategy. So maybe for patients that are a little bit sicker, lower albumin, really pushing that dose at the beginning can help them overcome and avoid colectomy. So moving on, okay, so not everyone can get infliximab in the hospital. And so for those patients, we think about cyclosporin and then another agent that we'll talk about right after that. Cyclosporin is an oldie but a goodie, okay? For a lot of reasons, it has fallen out of favor. So I am going to mention it, but not all your centers may give it because frankly, a lot of us were not trained to do it. We do offer it at our center, but I will tell you over the last year or so, it's really come down a lot in terms of when we use it. So cyclosporin is a calcineurin inhibitor in the same class as tacrolimus, and we use it similar to that rescue therapy for infliximab. Short-term response rates are great, 64 to 82%. So a lot of people leave the hospital without a colectomy. Why? What are the risks? People always want to know. So if your cholesterol is low, there's an increased risk of seizures with cyclosporin, which is why we want you to check that lipid panel at the beginning. Our threshold is usually around a total of 100. We can proceed. So cyclosporin can also cause renal insufficiency, hypomagnesemia, so they get lights on a daily basis. It can cause hypertension, headaches, paresthesias, and in low rates, mortality. Thankfully, we have not seen that. And of course, infection. How do we give it? So the thing about cyclosporin that's tough is that it's a 7-day continuous infusion. So all these, I'm also a hospital administrator now. It's tough to say, okay, let's keep everyone here for 7 days and then maybe we'll decide after that, right? Usually around day 3 or 4, you'll know if it's going to work or not. But if it works, then we urge everyone to stay for that 7 full days of continuous infusion, titrating just like a heparin drip to a level of 200 to 400. If they respond, then we convert to oral cyclosporin at discharge, usually 2 times the dose. And then we have to figure out what their exit strategy is. So cyclosporin to an immunomodulator, cyclosporin to veto or ustekinumab. Cyclosporin is usually given in circumstances where the person's already failed infliximab as an outpatient, or they can't get it for some reason. For example, if they have a history of MS, it's contraindicated to have a TNF. They have a history of antibodies to infliximab, they can't have that. If they have a history of tuberculosis or they have latent TB, then we try to avoid TNFs in that situation. There was a head-to-head looking at cyclosporin versus infliximab, and they did largely similar. So both are good options. Even looking out 2 years, the responses are similar. So they're both viable options, but again, If you respond to infliximab, you can get out in a couple of days. If you respond to cyclosporin, you're staying for 7 days. So it's a little bit tougher. Looking at a meta-analysis of different trials, including RCTs and non-RCTs, we see that the 3-month colectomy rate between cyclosporin and infliximab is similar. Looking at 12 months, there is some signal here at the bottom that infliximab may be a little bit better. And again, a lot of these randomized control trials, they use the standard dosing of infliximab, and they don't really dose escalate like we have discussed. So it can be hard to interpret if there truly is no difference or if it's just that it wasn't optimized. So keeping that in mind. Okay, so what if they're in the hospital and GI says, okay, well, they didn't respond to infliximab. Why can't we give them something else, right? Can we give them another medication? So yes, that happens sometimes. It's called sequential rescue therapy. And the main concern is a rate of serious infection. The rates of just minor infections or serious adverse events can range from 16 to 62%. If you're very, very, very sick and not responding to therapy, VTE is always a risk, but also has been reported in these patients that failed medical therapy, didn't get their colectomy, and then had sequential therapy, and then several cases of death from sequential therapy. And that was a paper published by Ilana Mazer in CGH in 2008. So always, thinking about the potential risks, advising these patients about really if we think that we're moving the needle at all with treatment, or if they're just better off with a colectomy. And then the use of sequential therapy, really at that point, if they're not already at an IBD center, we should really think about transferring them at that point. So new kids on the block for the last couple of years, the JAK inhibitors. The 2 JAK inhibitors approved for UC right now, one is tofacitinib that's been out for about 5 or 6 years now, and the other is upadacitinib, also known as Rinvoq, and that's been out for a couple of years as well. These are so tofacitinib is once or twice daily, depending on if you use the XR version, and upadacitinib is 1 pill a day. They work quickly. Okay, we have published papers looking at response within 3 days or 1 day for upadacitinib. I mean, they work really, really fast. And they don't have the same clearance issues as infliximab does. They don't form antibodies. And so it's been a really nice addition as a mechanism of action. If you're in the hospital, you're on the steroids, we would add a JAK inhibitor. It's been small studies so far looking at both tofacitinib and upadacitinib. So this is just one example of sort of a meta systematic review of different cases. People are using tofacitinib straight up after steroid failure. At the beginning, that was done, but now the tofacitinib, all the JAK inhibitors are required to be used after TNF failure. So you're going to see that more commonly now. So then you're going to see a conglomeration of that. And the 30 and 90-day colectomy-free survival is 85%. Out to 6 months, it's 69%. So it's quite effective in terms of maintenance therapy. Heads up, it's not clearly safe for pregnancy. There are cases where it has been shown to be okay in pregnancy, but we just don't have enough cases yet to really know. So that needs to be given up front as information to your women of reproductive age. Adverse events that are most common in the clinical trials include infection. Chiefly, one of the dose-dependent effects is varicella zoster. So for your patients born after 1990, if they had the chickenpox vaccine, a little bit lower of a risk for them, of course, because they've never seen it. But for your oldies but goodies that were born before 1990, when the vaccine was starting to be given, that potentially is at play as well, because most people had chickenpox before then. And we do recommend the Shingrix vaccination. So that is another drug in our armamentarium now that you're going to see a lot these days, because it is quite effective and people do like it because it's not an infusion, it's not an injection, it's a pill once a day. So this is just illustrating in some of these case studies looking at rapid response out to week 8 in terms of clinical symptoms, bowel wall thickness on intestinal ultrasound, their calprotectin scores are going down, their CRP is going down. So really, really nice responses sometimes we see to the JAK inhibitors, including upadacitinib here. Okay, and so some people say, well, how do you choose, right? So we talked a little bit about this before for the rescue therapy. The infliximab is going to be the mainstay. But if you have, for example, latent TB or active hepatitis B or something like that, where infliximab can be more dangerous for these viral infections, or we know that when you leave the hospital, you're not going to be able to get infusions done because of your insurance, then we may consider something like cyclosporin, which is a lot cheaper, or sometimes tofacitinib and upadacitinib can be achieved through samples or other ways that we can provide care that are not infusion based. We prefer for pregnant patients infliximab over cyclosporin and the JAK inhibitors. Cyclosporin is a maybe, but infliximab definitely tried and true for pregnancy. Tofacitinib, upadacitinib, as mentioned before, given after infliximab, given after TNF, as per the label requirement at this point. It wasn't at the beginning, but it is now. But cyclosporin is still an option in certain select centers where patients don't have other options or they have a contraindication to TNF. Okay. So just to finish up here in the next couple minutes, I want to go through just what you might see as an outpatient and just really to explain to our beloved surgeons on the call what really has happened over the last couple of years in IBD, because it's really been breathtaking. So if I can take you on a timeline of IBD treatments, this is 1998 all the way to 2021. For many years, we only had the TNFs. For almost 20 years, it was just the anti-TNFs. So we just kept cycling TNFs over and over again, saying, okay, well, you failed infliximab, go to adalimumab. So then enter vedolizumab, ustekinumab, the first JAK inhibitor, ozanimod, which is an S1P inhibitor, and it's another oral agent. In 2021, that's approved for UC as well. And then just in about a year and change, we had upadacitinib come out. First for UC, then Crohn's disease. Then we had the IL-23s come out. You see risankizumab, mirikizumab here. Then we had another S1P come out. I think they all came out within like 6 months of each other. We have etrasimod. And now, because infusions are very expensive, they're very hard to coordinate for some people. Now infliximab, which is that original infusion, is now also an injectable. And now Entyvio or vedolizumab, which was only an infusion, is also injectable. So now we can mix and match. So your patients may be on any variety or even combinations of these agents now. So it's been a really, really revolutionary last couple of years with treatment. So at least being familiar with the names of these medications is helpful. We're also getting a lot of information from head-to-head trials, which is very expensive and very hard to do. But we have, for example, the first head-to-head trial in Crohn's disease, which is called CView, which compared adalimumab, a TNF, to ustekinumab and IL-12/23, showing that both of these are very good first-line options for people that are bio-naive. We compared ustekinumab, which is an IL-12/23, to risankizumab, which is a dedicated IL-23, so more selective. And when we look at it in psoriasis, you can see here that the risankizumab, in terms of improvement in their psoriasis objective scoring, risankizumab is superior to ustekinumab. And again, we saw that in Crohn's disease, the sequence trial, seeing that there's improvement in clinical remission rates between ustekinumab, which is the IL-12/23, versus risankizumab, the IL-23. This is for Crohn's disease with a delta of 18%. And then endoscopic remission-wise, there was a 2x improvement in endoscopic remission for risankizumab over ustekinumab. So you're probably going to see a lot more risankizumab, which is also called Skyrizi, and you're probably going to see that on TV. But there is, I would posit to say, going to be less ustekinumab use over time and more uptake of the IL-23s, of which there are 3 out there now. These are secondary endpoints, again, showing in the orange that risankizumab, for some of the secondary endpoints, including endoscopic response, clinical remission at 1 year, steroid-free remission, did reach superiority for those endpoints. So again, just showing you that the IL-23 focus mechanism is really coming out, and we're going to have, I think, our 3rd one approved for UC probably this year. There's a lot of efforts to look at comparative efficacy of all these drugs now that we have so many. And you can see that some of these newer agents like risankizumab that we talked about, upadacitinib, if it's not infliximab or the TNFs like adalimumab, then these agents are really rising to the top in terms of response for luminal disease, including Crohn's. And then for the patients who have tried and failed a biologic before, for second line options, again, some of these newer agents, you're going to see a lot risankizumab, upadacitinib, because they do seem to be, based on their randomized controlled trial data, to be quite effective. For ulcerative colitis, there also was a head-to-head trial called Varsity, comparing adalimumab to vedolizumab in patients, and vedolizumab, which is Entyvio, actually was a little bit more effective in the anti-TNF naive population. So for those biologic naive patients, and overall, Entyvio was preferred, or vedolizumab for first line. So you might see someone come in sick on Entyvio because it is first line, and then they might move to a TNF after that based on this data. But a lot of doctors are starting patients first line on vedolizumab based on this information. Okay, so I think I'm gonna summarize now. So this is a quick and sort of high yield for the colorectal surgeon, what you might expect and why you might see your gastroenterologist doing these things for the management of patients with acute severe UC and or Crohn's colitis in the hospital. It is important to kind of follow that algorithm to make sure you don't miss C. diff, to make sure we don't miss CMV, to make sure we understand the severity of the illness of that colon. And also, it's important not to miss any of those really kind of life-threatening complications like toxic colitis. It's a multidisciplinary approach from the beginning, which I'm sure you guys all appreciate as well, because you hate coming in at the last minute and getting, that stressed out look from the patient. Some of our beloved colorectal surgeons let us know when we should have called them earlier. So IV steroids are going to be the mainstay, and then you move on to salvage or rescue therapy if you need to. And then deciding sort of what is appropriate in terms of rescue therapy and whether you're going to use one or two should be done in conjunction with GI. And then just understand that this is just a complete revolution in terms of the treatment of UC and Crohn's disease at this time, and we have more coming out. So though you may not know all the names, and there's so many different brand names and generics, but at least understanding what the patient has taken may be helpful for you. Because if you're colorectal and you're in the ER and this patient's like, yeah, I failed infliximab and I failed upadacitinib and I failed risankizumab, then you're going to say, all right, well, I'm probably going to have a very good chance of a colectomy on this admission. So it's just, it's helpful for you to know sort of like, these are the drugs that, doctors are going to reach for the really sicker patients. And so it's just helpful for, I guess, your prioritization and your understanding of it. Okay, so that's really the end of the lecture portion of this, and I welcome any questions at this point.
Perfect. Thanks so much for really the wealth of information. I think all of us appreciated it. I'm going to talk about a few questions from the Surgeon app. The first one is from Dr. Modi. The question is, are the JAK inhibitors associated with poorer post-surgical outcomes versus other biologics? And if so, how long do we need to hold them for non-emergent colectomies?
Yeah, so it's a good question. We have looked at a lot with the anti-TNFs, for example, in a randomized trial called Puccini. And the punchline of that was that, at least for immunosuppression with TNFs, and then potentially with vedolizumab as well, and ustekinumab, though there were smaller numbers in some of the studies that have looked at, we haven't seen increased risk post-op complications. When we're looking at JAK inhibitors, they're newer, okay? So we don't have as much robust data on that, but in general, the great thing about the JAK inhibitors is that they are very short-lived, okay? The half-life of some of these drugs, including tofacitinib, is about 3 hours, okay? So if you want to hold it for an elective colectomy, let's say, then you could hold it for a week, 2 weeks. It's so much so for for pregnancy, let's say, the guidelines actually recommend if someone wants to get pregnant and actually have another human inside of them, they say just hold it for a month beforehand. So for surgery, though I don't recommend holding it for, knee replacement or thyroid surgery, or even necessarily in the right situation for like a hernia repair, I don't think it's necessary because the data really hasn't supported that there is an increased risk of infection. But I know my colorectal surgeons, they have different feelings sometimes, but these are not as long lasting drugs as, let's call, the anti-TNFs, where they're given only once every 8 weeks. These are given daily. And so the half-life is very short. So I would really work with the gastroenterologist who's prescribing or the rheumatologist to come to a satisfactory decision together. There are some patients that they are so ill, their colitis is so bad that if they want to have surgery, I'm like, please do not hold it, because I don't think that the evidence is really there for post-op infection, but I do know that they're going to flare. So I think just getting a better idea of what is reasonable with that patient.
That makes sense, and a lot of like multidisciplinary active communication as well. Dr. Moslim also asked, why are JAK inhibitors not tested as first line?
So this is very interesting. So in 2018, when tofacitinib came out, I think it's 2018, it was first line. And then the FDA looked at some of the tofacitinib data from rheumatoid arthritis. So sorry, if for tofacitinib, it came out for UC around 2018, 2019. But for rheumatoid arthritis, which had received its approval before then, they said you must do a post-marketing study, a safety study, to look at your 50 and older population with at least one cardiac risk factor. So that data came out around 2019, end of 2019, and it showed for rheumatoid arthritis patients 50 and older with at least one heart disease issue, so hypertension, history of MI, stroke, history of smoking, other things, that in conjunction with methotrexate, those patients, compared to patients on anti-TNF for their rheumatoid arthritis, they had an increased risk of thrombosis, all-cause mortality, MI, stroke, and for the smokers, an increased risk of lung cancer. And then there was also potentially a signal for breast cancer. So that was called the oral surveillance study. And as a reaction to that, the FDA said every JAK inhibitor should be used at its lowest tolerable dose, because there was some dose-dependent response effects for that. But they also put a black box warning on the label. So it has to be used after anti-TNF because of that study. After that study in 2019, 2020, every GI publication for every GI Society conference has looked at the Trinetics database, large insurance databases, to see outcomes such as VT, all-cause mortality, MI, stroke, MACE events, and we have not seen a signal for UC or Crohn's. But it is still on the label, so we still do honor that and use it after TNF failure. But at the beginning, it was okay to use first line.
A lot of history there.
Yeah, it was, I would say for your patients who are a little bit suspicious, it was not good, because they were like, you told me it was safe. And then it was years of sort of looking through the data. But like I said, they are very effective. And so, we're still using it in the right patient at the right time.
Right. Dr. Jinwala also asked, what about the use of biologics in patients who get urgent or emergent subtotal colectomies instead of proctocolectomies? What do you think about the indication and kind of the timing?
Yeah, we do not stop a need for surgery if they received infliximab during the admission, or cyclosporin, or a JAK inhibitor. They go when they need to go. We don't wait, we give them the relief. It's usual practice at our institution, they get a subtotal with the endoleostomy, and then they have that rectal stump for about 3 months before they would move on for their creation of their J pouch if they choose to do so. But if they want to wait longer, if they're severely malnourished, or on the other side, if they're morbidly obese, we work sort of on optimization for that second stage. But you should not be waiting. If a patient needs a colectomy, just do the subtotal, do an endoleostomy. There's much lower of an infectious risk anyways with doing the endoleostomy. If you wait and that patient gets sicker over time, your surgery, I don't have to tell you guys, it's just, you're going to miss that window.
Thank you, Dr. Chang. That was a very, very informative talk, especially since I feel like I'm still just learning kind of all the medications for IBD. I'm Joyce. I'm one of the other leads for CRS virtual education. I have a question for you kind of about outpatient use of JAK inhibitors. Are we seeing these kind of used as single agents now, or are they always combined like we see it for the inpatient?
It's mostly single agent. Joyce, this is like an actually great question that we talk about it a lot, because so they actually work so quickly, like we're used to, okay, well, for let's say some of the IL-23s, we're like, give it, a month or, 2 months before you might feel anything. And the patient's like, well, I don't feel well today, tomorrow, So sometimes they require a steroid taper, right, to kind of control symptoms. But a lot of us are saying, okay, we'll just start the JAK, don't do a steroid taper, just start it, and let's try to keep you feeling better. And a lot of times, like even, I mean, it's not even that rare. Sometimes patients will message me later in the day and be like, I know this sounds crazy, but I already feel like it's working, So a lot of times we're using it as monotherapy. Now, in the very sick patients, both Crohn's and UC, we are seeing more of a trend towards thoughtful combinations of biologics and small molecules. So sometimes we'll do a JAK inhibitor plus ustekinumab or an IL-23 or Entyvio or vedolizumab, depending on the patient's prior response to other agents and prior treatment patterns. There's actually also some trials going on looking at using combination of TNF plus another agent. I think it's TNF plus an IL-12/23, because it's made by the same company, but, kind of moving towards that combination of agents, acknowledging that there may not be just one pathway to block to adequately treat the inflammation.
Thank you so much. We actually have another follow-up question from Dr. Moslem, who is asking about the potential for a phase 3 study. I think this is in reference to the JAK inhibitors.
Potential for phase 3 for what?
I think the initial question was the JAK inhibitors for first line.
Oh yeah, I don't think it's ever going to go that way. I've asked numerous people about it, and once the FDA sort of makes that designation, I don't think they're ever going to change their mind. So I don't think it will be, that black box warning will be removed.
I had one more question. I know it's not exactly related to necessarily the mechanism of action of a lot of these drugs, but I think we all have patients that get kind of lost in the system and they really just kind of present when they're acutely ill. I'm curious, and I know there's a hesitation to use a lot of the biologics if patients aren't obviously able to follow up, because then they develop antibodies. Like, how do you best manage some of those patients, because like the situation isn't optimal and that they're going to come back. So I'm curious if you have any kind of advice in navigating how to take care of those patients as well.
Yeah, no, so it's an amazing point. I think trying to understand what the limitations are, right? Is it you can't follow up because you don't have insurance? Okay, so then we're very lucky at our hospital. We have a VA next to the public city hospital for uninsured, and then we have our private hospital. So my IBD fellow, I'll say this patient needs to follow up at Bellevue, right? And so kind of trying to understand, like, is it an insurance issue? Is it because you don't want to take off work? Is it because you have a kid at home? Is it because you can't afford your copays, even if you have insurance? Like, what is the actual issue that you just seek care in the emergency room or just keep getting admitted, right? And trying to understand that can help us decide, okay, well, we'll get you care at a different hospital, or is it like you can't afford it, right? So then I might do one of the drugs that we can sample for that patient and then get them onto patient assistance programs. Most of these drug companies have either assistance for patients that are uninsured, or they have for the commercial patients, but let's say they have a really high copay, right? They have these programs that if you sign up, then it brings every dose down to like $5, right? The other part of it is, oh, well, I discharged the patient from the hospital and your next available GI appointment is in 3 months, right? So then they get sick and then they don't come back. So we actually did a quality project at our IBD center where the inpatient team emails every day the discharges to the GI IBD center. And we have to see that patient within 7 to 14 days of discharge. Every single patient, we close the loop and they have to have an option to see one of us. And so we've actually decreased ED visits that way. We've hooked them in with care, so I think a little bit of it is advocacy on the part of the patient and also just understanding what the defect is. You're not going to win them all, right? I think, having done this for a long time, sometimes it's just not going to happen. But for the ones that legitimately have an issue, I would work with your colleagues on figuring out how to do that. And then, this QI projects, everyone in fellowship has to do a QI project in residency, right? So that actually was one of our things that our fellow did. And it actually has been very impactful for us, which has been nice. So think about working with GI on that, because it's hard when you leave the emergency room to leave it all up to the patient. They're just not going to be able to get in.
Awesome. That's actually very helpful. And it's a nice reminder, I think, for everyone. So thank you.
Yeah.
I don't think we have any other questions on the Surgeon chat, but thank you so much again for your time. We all really appreciated it and learned a lot.
You're so welcome. I left my email here in my X handle. Feel free to always reach out with any questions or any clinical scenarios. I'm happy to help.
Awesome. Thanks so much, Dr. Chang.
All right. Take care. Bye-bye.